Hello, I'm Douglas Moeller. The question of what are the most important things to know about molecular diagnostics is probably the most common question that I'm asked. For formulary readers, I think that it's helpful to organize, to have an attack plan for molecular diagnostics by looking at the kinds of test categories that you might be dealing with. I think of 6 categories that are somewhat arbitrary, but I'll run through those in the next few minutes. The first is a screening test. We think of that primarily in prenatal screening for genetic defects, or neonatal screening also for genetic defects, but that's probably less of an issue for this audience. The second category of tests are diagnostic tests. That step that confirms a particular genetic combination or a particular gene profile or mutation that guides treatment from one group to an additional group. And typically in formulary, where you're dealing primarily with pharmaceutical agents, a diagnosis has already been established, and you're looking at is this treatment appropriate for that particular diagnosis. And so a diagnostic category is maybe less interesting. Somewhat more interesting, though, are prognostic tests. And prognostic tests are things like Oncotype DX. And in an oncology treatment for, say, breast cancer, if you have a certain gene profile that is established by Oncotype DX as a risk factor for recurrence, that has prognostic value and may dictate the aggressiveness of both the chemotherapy and radiation therapy regimen that is selected by the treating oncologist. And so prognostic categories can be potentially quite important in looking at the companion treatments with a particular chemotherapy regimen. Related to this is also what I call the fourth category, or predictive testing. The best example of predictive testing is probably KRAS. KRAS is a genetic marker in colon cancer cells and certain other tumors that corresponds to responsiveness to certain chemotherapy regimens. The interesting part recently about KRAS is that we know that there are more than 26 specific tests in our national catalog of KRAS tests. Each of those has been assigned a unique Z-code identifier for the tests to be identified by a laboratory and potentially to be confirmed in terms of payment by a health plan policy. At some point, if you have 26 different versions of a test, you might say to yourself, I wonder if those are all equally good in terms of testing for that analyte. That work is still to be done and is one of the open questions around molecular diagnostics of who validates the actual test efficacy. The fifth category that you hear quite a bit about in pharmacy literature are companion diagnostics, and particularly in oncology, there's been tremendous interest in, are there markers for treatment, either tumor markers or metabolic markers, that dictate the success that a particular treatment is likely to have, or that can help determine treatment progress along the way. There's some evidence that cancers actually evolve over time, and that some of these companion diagnostic markers, KRAS being one of those, actually need to be repeated to make sure that the cancer is still responsive to the current regimen. The final category are panel tests, and a panel test can be one of several different categories. You can have multiple analytes, but a single result related to algorithmic calculations. Oncotype DX for breast cancer is an example of a drug or of a test that assays multiple genes, correlates that with clinical outcomes in a reference population cohort, and then estimates the risk for each of the subtype combinations. And so that represents what in CPT jargon is an AAA test that can be found in Appendix O in the CPT manual. The second subcategory of panel tests are multi-analyte, multi-results, where there's actually as many as 20 or 30 or 40 different genes that are assayed in either a matrix array or, more commonly recently, in next-gen sequencing machines that literally provide a specific gene result with interpretation of potential mutations for each of the genes that are tested within that panel. Some of the challenges presently with multi-gene panels is how payers will manage that. The final category of multi-gene assays are actually exome testing, which is essentially a panel test for the 23,000 or so human proteins that are about 2 or 3% of the human genome, and finally, literally, the human genome test itself. Of considerable interest recently is that the laboratory portion of human genome testing has now reached a price point of about $1,500 for that laboratory element, with the interpretive component still being $6,000 to $8,000 to $10,000, making the total genome test and interpretation around $10,000 to $12,000.